This was my contribution to the Cluster Steps platform. Oh my, innovative trial design and how to choose appropriate primary outcomes for neonatal trials session at the Pediatric Academic Society 2026 meeting in Boston. First of all, I would like to thank Carl Bacchus and Anoop Kataria for inviting me to present on trials during emergent resuscitation with a specific focus on the SURVIVE trial. Here you can see my disclosures, and I would to highlight that I will talk about a new chest compression technique, which is called CC plus SI, which we developed and are testing during the SURVIVE trial. Why cluster trials are feasible or possible during neonatal resuscitation. Well, neonatal resuscitation is a team-based intervention. It is time critical, and regardless of the location in the world, it is protocol driven where you follow a certain algorithm. For many trials, there is individual randomization, but this can be problematic during neonatal resuscitation because it could disrupt the workflow. For example, previous studies like the SANE trial, where Anoop, Liz, and myself have participated, where from birth to the first intervention, there was 30 seconds to make the decision to randomize the child or not, and to open an envelope in that time frame. That can lead to stopping the interventions you are supposed to do, potentially delay some of the ventilation, or given the heat and the stressful situation of that moment, you forget to randomize it all. And it might not be always feasible in emergencies, particularly when there is certain things to prepare potentially for deliveries. Cluster trial has the ability to solve some of these problems. You use one protocol for the whole team, for the whole hospital. If you randomize the hospital, it can study more easily real-world behavior because all the patients are automatically included because the hospital is randomized to an intervention, and they are feasible at birth, as I will show you in a few minutes, because we randomize the hospital or the team and not the baby. So what cluster trials are available? Well, we could do a parallel comparison where NICU A is one approach and NICU B is another approach. We could randomize them to a crossover cluster trial where you start with one intervention and after a certain number of patients, you flip to the other intervention, or you start with the intervention and then flip back to control. So these are the two options for a crossover trial. Or you do a step bridge where everybody starts in control and then slowly you change over to the intervention until all the sites are basically in the intervention group. These are the most commonly used cluster trial designs. For neonatal resuscitation, the most common used approach is the crossover cluster design. And here you can see studies over the last years which have been done with this cluster crossover design. MinV, which is a study on cord management, Hilo, Oxyprim, and Aeroplane, they all study oxygen, as well as the upcoming RESAIR trial. MVP is comparing two ventilation approaches at birth, and SURVIVE, which I will talk later about as well as VERSE, we're focusing on chest compression and vasopressor administration. What are the strengths and limitations of cluster trials? Well, the strengths, as I mentioned already a bit earlier, is that this is a real-world practice where as a hospital is randomized, you're able to include all the patients available and not a selective sample. For example, if you would do antenatal consent, or even with deferred consent, you potentially, again, don't get all the babies because you need setup time and other things. So you sometimes get a much better real world practice. These are in general team-based intervention, um, like oxygen or cord management, and not individual interventions. It has the potential to reduce contamination because, as I said, you change your hospital standard of care or your hospital policy, and so that the control group accidentally or intentionally get the experimental group treatment is less likely. Classical example is with cord management, where people see the benefit of cord management and might not want to do a different cord management approach in the control group. And that's a problem in particular for individual randomized control trials, while in cluster trials, when you do this one approach, this is the policy and everybody has to follow it. And they're easy to implement because there are small changes in your algorithm. Like if you look in oxygen, your starting oxygen concentration is like 21% or 30%, and nothing else changes in the algorithm. Limitations include you need a larger sample size, and this is then reflected in the intercluster correlation or ICC, and we'll have on the next slide more detail about that. The variability in the site, which means how sites treat patients outside of your intervention. There is temporal effects where the outcome of the intervention can change over time, and you can have a learning or a decay effect. Learning effect, classic, which wasn't a cluster trial, but a classic example was resuscitation attached to the cord, the ABC3 trial, which showed that sites who had a lot of experience doing this, or sites at the beginning have never done it, over time they had a steep learning curve and the outcomes improved. Could be the opposite, that it works well and you have a decay in the approach, or you have time trends. The power you do depends on the cluster and not on the number of patients. Classic, we had in Hilo, we had a certain number of sites, some dropped out, and if we would have not recruited new sites, our power would have been only around 78%. With the new sites recruited, we are back to like a percentage of power of 82%, which is above the 80% we're calculating our sample size at. So the power is much more dependent on the number of clusters compared to the number of patients you recruit, and your analysis is much more complex than we often do with individual randomized patients. Now, the intercluster correlation is basically like a click where it defines how similar people are within the same cluster, or how similar patients are treated within the same cluster. As one NICU, you might have really similar patients because it's your patient populations, but if you have many different NICUs, you will get variability in how they treat. So the typical ICC we have for any of these cluster trials is somewhere between 0.1 to 0.05. And for our trials, we take them from the Canadian Neonatal Network, a database including over 30 NICUs across Canada, which submits data to the network for benchmarking, and we can use this to calculate our ICC. The primary outcome needs to be something which is a patient-centered outcome, mortality, BPD, or HIE, because they are the same across each cluster. Outcomes which are more driven by practice, like rates of intubation or NICU admissions, they are more challenging because they are different at any NICU, for example. Now, in the last few slides, I want to briefly talk about the SURVIVE trial. And the SURVIVE trial is a cluster randomized trial which will compare the standard of care of 3-to-1 chest compression with chest compression with sustained inflation. In this presentation now, I will only briefly talk about CCSI. If you would like to know more, there are many more talks about CCSI on our YouTube channel or on our webpage, where you can see the information how to find them later in the talk. What is the difference between those two? For 3-to-1, you provide chest compression 3 times, you pause, and then give 1 inflation, and then you do 3 chest compressions again with 1 pause for an inflation. Doing CCSI, you use a high distending pressure, which we term sustained inflation, and provide continuous compression. The advantage is that with every chest compression, regardless if it's 3-to-1 or CCSI, whenever you push down on the chest, air comes out of the lungs. So you de-recruit the lung. With 3-to-1, you push 3 times onto the chest, 3 times air comes out, and then you give 1 inflation where you re-inflate the lung, and then with the next 3 chest compression, you push out air again until you inflate again with the next inflation. During CCSI, you have a high distending pressure or sustained inflation. You continuously do chest compression, and again, with each compression, air comes out. But doing chest recoil, because of the sustained inflation or this high distending pressure, air flows back into the lung. And as you can see on the bottom left, you get positive, so lung recruitment, doing CCSI, while you de-recruit the lung doing 3-to-1. In our initial feasibility trial, we showed that the time to ROSC was 75% faster compared to using standard. There were 2 neonatal deaths with this new technique, but the majority of these babies were 24 to 26 weeks gestation, and therefore mortality was in general high. But that certainly is something which warrants further investigation. The second study, which was a cluster randomized trial across 4 sites in Canada and Austria, showed similar results. You can see that the time to ROSC was lower, it was 90 versus 615 seconds with 3-to-1 and 90 seconds with CCSI. But given the analysis as a cluster trial, this was not significant. Similar for mortality, while it was higher with CCSI, it was not significant given the low numbers. We were recruiting with only 11 kids with CCSI and 14 with 3-to-1. A meta-analysis we did just reaffirmed the results from the 2 individual trials that the time to ROSC is significantly less with CCSI. In this study is by up around 2 minutes on average. Mortality was not different. But this information was good enough for us to do the next step, which is SURVIVE-2, which will look now at mortality to hospital discharge in 556 infants or 278 infants in each group to detect a 20% reduction in mortality. We will include 28 weeks or older and term babies who require chest compression in a delivery room. And as this is a cluster trial, the hospital will be randomized to up to 24 months to do CCSI or 3-to-1 chest compression on ventilation. And here you can see the algorithm of the trial. You can see that everything is the same from an algorithm perspective as you would do it in your current neonatal resuscitation algorithm. The only difference is that the moment you start chest compression, as your hospital is randomized to CCSI or 3-to-1 chest compression to ventilation ratio, this is the approach you're doing. And before that and after that, you do what you always do as per your routine hospital policy. Now, the take-home messages are that cluster trials are feasible if the intervention is team-based. When you have contamination, likely, like for example, as I mentioned, court management, then cluster might be a better approach, and implementation matters. But always remember, we need to choose our outcome carefully and need larger sample size. And once again, this is a call. If you're interested, you can join the SURVIVE-2 trial by either coming to the Sunday trial investigator meeting, which I invite you now to it, or reach out to us on Twitter or X, our webpage, or via email or YouTube. And also here you can find more information on CCSI as well as SURVIVE, and if you want to join us. And with that, I say thank you for your attention and looking forward to any questions or discussions at the end of this session.